Hi there, my name is Mackenzie Rice, and today I am presenting my DNP scholarly project, the LVEDP-Guided Hydration Sliding Scale Protocol to Reduce Contrast-Induced Nephropathy. The project was completed in the adult cardiac catheterization setting, and the focus on the practical gap that I saw clinically was hydration was being used for renal protection, but it was not consistently individualized using already available hemodynamic data. So going into the presentation, my chair is Dr. Maria Snell. My course faculty and the second reader for the project is Dr. Sarisa Moore. The community member is a former coworker and manager, Patricia Baker, RN in the cath lab. And then the key site stakeholder is Dr. David Chevelle. He's the chief of cardiology and interventional cardiologist. He's really the person who advocated for me the most in terms of the project and really supported it and made sure that all of the other physicians and fellow employees were abiding by the guidelines of the protocol. The workflow for this presentation will be going over the background, the clinical question, the evidence and the framework behind that, the methods, samples, analysis, the results, interpretation, and the implications and what it means for my future practice. So contrast-induced nephropathy, it's a concern for cardiac patients, especially due to pre-existing conditions. It necessitates individualized hydration strategies to balance kidney protection with potential heart complications. Contrast is necessary for many of the procedures we do. As you can see on the picture on the right, that's Dr. David Chevelle. The key site stakeholder, you can see contrast being used to look at the coronary arteries. It remains a safety concern after contrast exposure really for any patients, but really the cardiac patients with overlapping risk factors, especially CKD and diabetes and heart failure. The key is prevention must balance kidney protection with avoidance of fluid overload in our heart failure patients. So the project aimed to reduce contrast-induced nephropathy after cardiac catheterization by using the left ventricular and diastolic pressure to guide hydration rates. A pre- and post-quality improvement design was used to evaluate the effectiveness of the sliding scale hydration protocol. So literature supports the clinical importance of CIN and contrast-associated acute kidney injury due to the increased monitoring needs and resource use. And that's not including the increased hospital stay and the costs associated with acute kidney injury and maybe unnecessary dialysis. A more individualized approach to hydration is needed, considering the patient as an individual rather than grouping them as a whole population, and the procedural factors. So as you can see, as previously stated, the risk is higher for CKD, diabetes, heart failure, the hemodynamically unstable, and those who have a higher contrast burden from increased length of procedure or having a more complex case. I used the KDIGO criteria for my project in terms of basing the definition of what acute kidney injury is. So contrast-associated AKI risk varies by baseline kidney function and patient context. Hydration is a cheap, effective, and central prevention strategy, but fixed hydration strategies may not be safe or effective for every cardiac patient. This is in terms of especially heart failure patients who have higher filling pressures in their heart. They may not be able to handle as much fluid. Because these patients have heart failure, oftentimes you'll see physicians limit the fluid they are giving these patients without actually using a direct measurement from their own heart filling pressure and just grouping the heart failure patients as one entirely and saying, you know, we're not going to give them any fluid after, or we're only going to do 25 cc's an hour. So the Poseidon trial demonstrated that adjusting fluid administration based on a patient's LVEDP during a cardiac catheterization can prevent contrast-induced acute kidney injury. This concept was integrated into the catheterization lab workflow for my project. The Poseidon protocol, I believe it came out 10, 15 years ago, and we used it at a previous facility I worked at in San Diego, and they saw really good effects afterwards. And in terms of patients having to stay afterwards or having acute kidney injury that were high risk, they really eliminated some of those factors, and overall patients benefited from it. And so the clinical logic behind it, which you can see on the chart, is you increase the hydration protocol when the filling pressures in the heart are low, your LVEDP, and then you limit fluid when your pressures are too high, limiting it to only 1.5 mils per kilo per hour, 4 hours after, to flush all the contrast out. So the Squire 2.0, a quality improvement reporting framework, is what I use to organize the project systematically. It helped describe the context, define the intervention, identify the measures, explain the analysis, present the results, and interpret the findings with the limitations. So a little bit more in terms of the sliding scale hydration protocol. So when patients were worked up preoperatively, whether that was inpatient or outpatient coming in as an elective, they would receive 3 milliliters per kilograms for an hour, depending on their weight, sometimes like 100, 150 to maybe 200 cc's an hour. And that was what usually the standard was, 100 cc's an hour prior to this. And then during the procedure, based on those measurements that we would be obtaining, that is the hydration rate that we would follow for 4 hours after. So in terms of the background and significance of LVEDP for people who don't have a cardiac cath background or aren't as familiar, you can see the top picture. The arrow pointing is what the left ventricular end diastolic pressure is. This is a measurement that is obtained at the end of diastole near the onset of the QRS complex. It's ultimately the decision point of this hydration rate protocol, and it's based on the filling pressures. You can see in the lower picture, this is one of the catheters we use to obtain the measurement. As previously stated, this is an already pre-obtained measurement in most standardized cardiac catheterization procedures, regardless if an intervention is done. So it's not like we had to do any additional work for my project besides just prescribing a fluid rate post. So a quantitative quality improvement design with a retrospective pre and post intervention comparison was used to evaluate the workflow change. The independent variable was the study phase, and the dependent variable was the contrast-induced nephropathy status, analyzed using data extracted from EPIC reports. I compared the CIN rates before the protocol and after the protocol was initiated, and everything was de-identified as well. So as previously stated, the setting was in the adult cardiac catheterization lab. All the patients were over 18. There was no consent needed because this is already a pre-obtained measurement. It was just a quality improvement initiative. There was no direct patient recruitment. It was retrospective, de-identified. As you can see in terms of before the intervention and the post-intervention, I put the mean age just for, extra knowledge. And there were slightly more males for CIN in both groups in terms of before the intervention of the protocol and after. The main outcome measure was CIN status using the KDIGO-based creatinine criteria with additional variables including the LVEDP category, hydration rate, age, and sex. The project followed ethical guidelines, including a review, and data was de-identified for confidentiality. So some ethical safeguards. It had to go through the project approval committee. There was site approval before any data collection was made, and it was de-identified. There were password protected files, limited access, and aggregate reporting only. So for data analysis, descriptive statistics were first used to summarize the sample and the available clinical variables. The primary analysis was a lower tail z-test for the difference between the two independent. Descriptive statistics summarized the sample and the clinical variable, and a lower z-test compared pre and post interventions and CIN rates, reporting absolute and relative reductions, confidence intervals, p-values, and achieved powers. Implementation of this LVEDP guided hydration protocol resulted in a 50.8% relative reduction in the rate of CIN from 34.27% prior to the protocol being placed to 16.85%, and that was with the protocol being placed. So inferential analysis supported the clinical finding of the statistically significant decrease in CIN after implementation with a 95% confidence interval for the absolute reduction ranging from 8.54 to 26.30 percentage points. The lower tail 2 proportion z-test supported the rejection of the null hypothesis. And the confidence interval did not cross zero, supporting a true reduction in CIN rate. So the process measure demonstrated the intervention practical application. It showed very hydration rates, as you can see in the chart, based on the LVEDP levels, supporting intervention fidelity and clinical relevance. This was important because it showed that the project was not simply another fixed hydration approach. The protocol actually distributed patients across different hydration rates based on their own filling pressures, and it supported the intervention by helping to explain why this was clinically meaningful. So some of the study limitations, it includes that it's single-site retrospective design. There was a short evaluation time frame, you could say, and there was a lack of control for all patient-level co-founders. Some of the patients also, too, they have baseline severe renal failure or they are getting dialysis, so those patients weren't included. So in terms of interpreting this, the findings were strong for a local QI impact, but broader generalizability requires further study. So the findings answered the project question. CIN rates were significantly lower after implementation of the LVEDP guiding sliding scale hydration protocol. What made this intervention practical was that it used an existing procedural value rather than requiring extra new equipment or a separate screening process. The project standardized hydration, and it did not make hydration fits one all approach. It created a structured way to individualize fluid administration based on a patient's filling pressures. So to me, the most important clinical interpretation is that hydration should be viewed as an active renal protective intervention. It's also a very cheap, cost-effective way for hospitals to prevent longer stays and prevent patient harm. In the cath lab, small little workflow changes like this can matter, especially when they are simple like this. It's easy to initiate, and it's easier for the entire staff to follow through with the protocol when it's something that we're already doing, just not advocating for. It's measurable and it helps patient outcomes. So, a protocol for individualized hydration in cardiac catheterization patients improves communication and it reduces variations in care. It considers each patient's unique needs, balancing renal protection and volume overload risk. So, implications for practice in terms of other things to consider. Post-procedure monitoring should include urine output, fluid tolerance, respiratory status, and creatinine trends. It supports the interprofessional communication among all staff to be involved, the cardiologists, the hospitalists on the floor who are managing care after an intervention, or if they are the ones taking care of the patient before the intervention, if it's an already in-house patient, and leadership in terms of quality improvement and saving your department and hospital and patients money. A structured algorithm may reduce variation from provider preference alone. And the individualized hydration supports patient-centered care for patients who already have a real renal and cardiac risk. So, recommendations and sustainability from my project is to continue a LVEDP-guided hydration for all eligible cath lab patients. It's to embed the protocol into order sets, procedure checklists, and documentation workflows, making it easier for all of the staff to understand the protocol and for it to be easier reinforced and abided by if it's already in place, where the patient's kilograms can just automatically calculate the fluid needed rather than the physician or the nurse calculating that by hand or by themselves. So provide quick staff education on LVEDP categories, the significance of it, and the hydration rates. Audit CIN rates, creatinine trends, LVEDP documentation and order completion. Assign ownership to a cath lab quality lead or nurse champion. And then evaluate spread to other contrast exposure settings only after workflow review. Sustainability depends on hardwiring the protocol, not relying on memory. This protocol doesn't necessarily only have to be involved in cardiac catheterization procedures. Eventually, it can work towards helping patients in-house who are just getting a CT scan that are considered high risk for renal injury if they are already admitted for sepsis, or if they're in acute heart failure exacerbation, or if they already have CKD and make their own urine and they're on the borderline of needing continuous renal replacement therapy or whatnot. This could go over to other units as well, not just necessarily has to be in the cardiac cath lab procedure. So in terms of conclusions and personal reflection, this project demonstrated a statistically significant and clinically meaningful CIN reduction. It was a LVEDP guided hydration that used data that was already pre-available during a catheterization. It didn't require any extra effort by the physicians or the nurses or techs in the procedure itself to obtain. It was just a matter of using the information that was already available to us. The project reinforced that QI work must be simple enough to fit real workflows, which I feel like this project did a really good job of identifying simple, easy, cost-effective measures that can really improve patient outcomes and save hospital costs. For future work on this project, Longer follow-up, larger sample, additional risk variables, cost and length of stay outcomes would be pretty interesting to see. And then in terms of how this has impacted my learning experience, my DMP, and possibly future practice, it strengthened my ability to connect bedside practice, evidence data, and system level change. As you can see on the bottom, just a reminder that this simple, cost-effective way, even though I wasn't able to do numerous settings, it was only focused on one, there was a really big significant impact where the CIN did decrease from 34.3% to 16.9%, just in a matter of months, so almost 50% reduction. And here are my references for your referral. Thank you for listening.